Wednesday evening, everybody. I'm Chris Therien, former Philadelphia Flyer defenseman and current reporter for the Flyers and pre- and post-game on NBC Sports Philadelphia for all Flyers home and away games. I'm joined again by the Flyers head trainer, Jim McCrossin, a man of many trades in the medical industry. I'm very, very pleased today to have Dr. Jason Mora, who is a guy here, works at Recon Orthopedics, a doctor, does a lot of hip and knee replacements, as well as some robotic-assisted partial and total knee replacements. So you're going to be an interesting guy to talk to, because that sounds pretty cool. And of course, for most of you watching and are here, we don't need much introduction for this guy. He's a former movie star that starred in a couple of movies over the years. But no, I think we all do know Ian Laperrière, Flyers assistant coach. More importantly, a good friend to all of us, and a player that played 1,000 games, has been extremely versatile in his career, has won the Masterton Trophy for dedication and perseverance to the game of hockey, and is now a full-time athlete afterwards, as he's triathlons and sports afterwards have been a big part. Lappy, thank you for being here. We love to have you, buddy.
Thanks for having me.
And we are going to jump right on into this, and Jimmy, you're going to be on up to bat here first, so we're going to start off here with our questions. And the first thing is this week, we said the first thing is knee osteoarthritis is our sports medicine topic of the week. So I'm going to ask you straight up, Jimmy, what is osteoarthritis?
Well, I think all of us can attest to it because we've all either had players, patients, friends. It's really the number one joint disease that retires athletes early. And why? It's painful. And if it gets up to a certain grade, right, Doc, you're going to be taken out of the game. And we've played with players, Keith Jones, they've had this in the knees. And Lab, I'm sure you've seen players that had to retire early because they just couldn't play the game anymore effectively. And so it's really a joint disease. It's a joint disease that takes you out of the game, but it's really strongly linked to aging, obesity, right? Aging, obesity, and repetitive motion, such as, you think about what we do in ice hockey. You think about what a carpet layer would do, and up and down, up and down. It's that repetitive motion. So.
And really, you just mentioned, I know we're going to talk about it later, but you talk about a guy like Keith Jones, one of the broadcasters that ended his career. This is a career ender, correct? When you get this, I mean, is it, we used to hear about the stories when you were younger, Bo Jackson hip, you get that type of injury and it's lights out for your career. Is that the same today with that kind of injury?
Well, you know what, I'm going to let the doctor handle this one. Well, you know what, because it could be. But and I'm going to skip ahead a little bit because there's ways, there's certain measures you can do to help prolong the need for a hip replacement, a joint or a knee replacement. Correct, Doctor?
That's correct.
Again, I'm Jason Mora, one of the reconstructive orthopedic surgeons. I did fellowship training in hip and knee replacement, revision replacement, as well as joint preservation as well at Langsdale Hospital in Manhattan. And we see a wide variety of these, and the reality is, some of our patients, we do see a lot of, elderly patients, older patients with degenerative changes, but the reality, the goal of this talk is before we get to that point, what do we do, what modalities of treatment can we do for these patients before we have to talk about joint replacements, which really is our last kind of stage there. And for an athlete in particular, the reason, we talk about certain injuries such as ACLs, meniscal tears, and things like that is that we try to tackle those as early as possible because those could be some kind of speed bumps in the road, if you will. If you think of it as speed bumps in the road, those can cause kind of osteochondral injuries, or that smooth, bony surface that allows our joint to glide with fluidity and as little friction as possible. So when you have these certain injuries to like a meniscus or something like that, it becomes a flap or something, or a tear of an ACL or such, which can throw the biomechanics of the knee off. It can cause a lot of different contact pressures, which again injure the cartilage, which can be career enders. Because in reality, there's two reasons why people ultimately have to go to a replacement, and that's decrease in function because they're no longer able to do what they normally used to be able to do, or because of debilitating pain.
Which actually leads me to my next question on it, guys, is approximately how many total knee and hip replacements are performed in the United States each year?
I dug around for some research to get the latest and greatest on this one. From the American Physical Therapy Association, 790,000 knee replacements last year in the U.S. alone, 450,000 hip replacements, and they last about 25 years if you take good care of them. And they're saying about 8% of them are still, 80% of the knees are still functioning. To what degree they didn't go on, right? They didn't go on to say, because at some point, you're seeing, I'm sure, doctor, you're seeing knee replacement, hip replacements done much earlier than they were when I was your age. And if they're lasting for about 25 years, we want you to be active. I had my knee replaced. Had his knee replaced. And you want to stay active. You can't stay in the game because really I haven't seen any player come back other than Therien and Hatcher. He tried to come back when he had his knee replaced, but couldn't because your mechanics are thrown off and you're just not as effective. We did have one player come back with a total hip, but he didn't play for us. That was the Ontario Mitchell, right? We didn't come back and play NHL hockey, but he came back and played AHL hockey for a year. Then he had to have his other knee hip replaced. And he went back over to Finland and just said enough's enough and got into scouting.
Which will take me right over to the next one, Doc, probably for you. How common is osteoarthritis?
It's very common, and the reality is there's if you take X-rays from the general population and over 70 years of age, you're going to see well over 70% of those people having osteoarthritis of some sort. Now the question is, are all of these people symptomatic? And the answer is no, in reality. And we don't just treat the X-ray. It's got to be more of a functional, is there a disability involved with these patients? Do they have some sort of pain as well? So it's a very common, pathology that we are seeing.
And we have a couple more here on the actual what happens with these injuries, and one of them is, what are some of the non-surgical interventions that can prolong the need for total knee surgery?
Yeah, so what I tell all my patients when they come in and they have evidence of osteoarthritis on X-ray, which is that collapsing of that joint space that we see, and the reality is that I always tell them there's two main options. There's non-operative and there's operative choices. Though we're surgeons, we try to do everything possible to avoid surgery if we can. And really the components are four major things. One is anti-inflammatories to help with some of the pain, some of the inflammation that can happen. Some people can get fluid on the knee if you see, and that's really your body's way of kind of protecting its knee. It's that it sees a stimulus, it feels that there's irritation in the knee, so what it tries to do is this lining or the synovial cells in your knee actually stimulate a fluid response to try to cushion the knee. So that's like a protective mechanism. The second thing we try are different types of injections. The more common ones being cortisone injections, which and research shows can be safe about every 3 months without being too much detrimental to the actual chondrocytes or the cartilage itself. And we hope to gain pain relief and inflammation, decrease inflammation in that. And there's a variety of ways that people respond to that. Some people respond very well. Some people it doesn't really work for it too well. There are other injections that we try are called viscosupplementations, which is hyaluronic acid. Now, hyaluronic acid is a normal component in our normal knees, joint fluid. And what the idea is that we can add this component and stimulate a normal, healthy amount of kind of fluid to cushion a joint that's now very friction high to a lower friction, act as like a lubricant in the knee. One of the last things we do is always keeping some sort of physiotherapy. I do a lot of physician-directed physiotherapy, in particular, trying to strengthen that quadriceps muscle in your hip abductors. Because the reality is when you have a lot of pain in the knee, what can happen is you tend to favor it with the other leg. As that's happening, your muscles want to stiffen to act as like a splint in your knee because it doesn't want to move as much. So what happens, you start getting stiff, you lose your range of motion, and that certainly leads to favoring the other side more so. And then it leads to an atrophy of your muscles. So it's really important to get that muscle strength going for non-operative reasons, your overall health of your knee. But if you are going to go to a total knee replacement later on, it's very important to have that strength so you can rehab afterwards a little bit better.
Can I just
Yes,
add one
please.
thing?
Yeah, for sure.
Listen to what the doc said, right? That's the critical point, is that, make an educated decision. If you don't feel you can do the exercise that the doctor gives you to do at home, right? See a reputable physical therapist. See a physical therapist that's going to steer you into the right direction, working with the doctor to get that leg as strong as it can possibly be. Because like the doc said, if you have to go down the road of surgical intervention, you want that leg to be strong, right? So you're really doing yourself justice by getting yourself into a good rehab program.
And we have a last and final question here, and it's probably one that would be more for the general population than perhaps just your professional or amateur athlete. But what are some of the risk factors of osteoarthritis? I would think, just thinking of myself, obesity. People that probably do a lot of work squatting, I would think it will lead to a factor, but that would be an interesting one.
Yeah, I think, as we said in the very beginning, age is a factor, okay? Being female can be a factor, right? Obesity, America's not getting slimmer, that's for sure. Family history of osteoarthritis. And as we said before about mechanical factors, something that you really can't eliminate because it could be the sport that you chose, the trade that you chose, right? And it's just taking its wear and tear on your body.
Which brings us now to our special guest this week, the great Ian Laperrière, otherwise known as Lappy. Lappy, it's great to have you. We said that when we came in, but really you're a unique case, and you can see the condition you're in right now. I've ran a little bit. I've not completed, but you've done. We're going to talk about the Ironman. But you're a guy, you played a long time in the league. We both played a long time in the league, and you leave with injuries. When you play 10 years in this league or more, you cannot come out of it scar-free. It's impossible. So, but you retired. You got into coaching. You stayed in the Philadelphia area, and you became a triathlete, for a sense. Then you ended up getting hurt. So how was that when you had to take your entire career professional, and then you end up having osteoarthritis from your days as an amateur athlete going back to triathlon? Take us through that, Lappy, and really what that was for you and how it ended up being for you at the end of the day.
Well, it's just like Doug said, like you were talking about ACL and meniscus, and all my career, like 25 years ago, I had my ACL repair on my left. And some meniscus damage, it wasn't a clean cut. They had to remove some meniscus, and they did that to my other knee too, which this one's good. Hopefully it's going to stay good, but my left knee there, and like Bundy said, after playing all my career, I had to retire because of an injury, nothing to do with my knee, but I still needed a challenge. And where I live, I got a bunch of triathletes there. They're all like, they're from 50 to 75 years old triathletes, Ironman and everything, and they kind of challenged me to do that. And I still had some juice and drive to do something even after. I couldn't play hockey, but I needed a challenge, and there's no bigger challenge than Ironman. And I did that. Didn't have any knee problems, but after the Ironman, I was training for another Ironman, and my knee started bothering me. And I talked to Jimmy. He got me in contact with the doctor there. Went to see the doctor, and fair enough, they took X-rays and they looked at it, and I didn't get a full knee replacement. I got a partial knee replacement on the outside. And for me, I could have waited. I could have stopped running. I could have just be on the bike and swim. But at the time, I was 43 years old, and I'm like, I still want to be active. Like it's time to do it now. Maybe they say, well, you can run on it. We don't recommend you to run on it, but if you do, you might need a knee. You talk about 25 years. I might need a new knee in 15 years because I push it too hard. Well, I'm willing to take that gamble, because for me as a human being, I need to be active. I need to stay lean. I need to, not only for my knees, but for my mind more than anything. I need to be active, and that's why I got my knee done. The doctor did an unbelievable job. It's been 3 years. I'm running faster than I've ever run before. I'm not sure it's the best thing to do. I'm not running as much as I used to, But when I do probably run 3 to 4 times a week, which I know that don't look at me, I know it's not recommended, but for me it's more like it's more for my mental health, and also like being an assistant coach, like you said, I'm a big believer that you lead by example, and I like to show to the ring there, you know, joke around about my workout, my run, whatever, but I like to look fit because we're asking our players to look fit, and that's the way.
And I'll just stay with you for a second here, Lappy, but you know, you're running, I know where you're at because I was in it. I'm not quite doing it at the level you were, but how are you feeling? I mean, you've gone through a lot of these injuries and you are running 4 times a week. I know you just have to lay that out to Jimmy. He's not happy about it, but how are you feeling though? I mean, after all you've been through.
I feel great, like, you know, my knees, that, like, I feel it sometimes, it's more like I told you 2 days ago, Jimmy, the weather, like, I feel it, like, when it's 2 days ago, the weather was awful, and first time in months, I start feeling my knee, I'm like, oh, maybe I'm doing too much, but I went for a 7-mile run today, I feel okay, and, and it's just like, again, I had brain injuries, head injuries, and I go back to, I need to stay active, and for me, running is, meditation almost. I go out, I listen to podcasts and music or nothing at all, and it's really helped me mentally more than anything.
I can attest to that. It's like therapy. Yeah, mental therapy too. So it's very rewarding. So great stuff, Lappy. We are going to actually take some questions from the crowd. We encourage you guys to ask because we have T-shirt giveaways tonight and flyer stuff, of course. But if you guys have anything that you'd like to ask Dr. Jason or Jimmy, Lappy, myself, preferably those 3, but I certainly will open it up. I know you had a question last week. I know you're going to have another one this week, aren't you? But ladies first. Come on up.
Oh, I have to come up.
Oh, yeah. Or would you like me to bring you the mic?
Thanks, Doc.
I guess I have to leave my mask on.
Whatever.
I don't know how you guys run without music, that's just weird. I can't even run without having something going. In your surgeries, how often do you do allografts? How often do you use donor tissue and donor bone? Is that like a common practice that you guys use? And if you do you find a better outcome using donor tissue? Questions?
So that was a good question there. This is just to qualify a little bit. Is this, or clarify, I should say, when you're talking about donor allografts and different supplementation, are you talking about during a knee replacement itself?
During a knee replacement or hip replacement, or even when you're doing tissue repairs, do you use allografts a lot?
Gotcha. So when we use allografts, which is usually cadaveric bone or autografts, we're using our own type of tissues or things like that. That's usually typically in reconstructive before we're getting to a knee replacement or so. So when doing like an ACL, you can use your own tendons, whether the patella tendon, quadricep tendon, hamstrings and such. When it comes to the bony work of replacement, the actual procedure itself doesn't usually require any supplemental allograft or autograft or things like that. In more complex primary cases where there's a lot of deformity and such, there's different augments that we can use, which are usually metal-based as well, but not as much in replacement.
Yeah, I'll give you the response from last week too, because that was last week's talk on ACLs.
Yeah.
And that's probably more what you're looking at, but just so you know that using a cadaver graft is that there's I think it's 2.6 to 4.2 increased rate of failure compared to using your own. So again, the same answer as I gave last week is that make sure you talk about it with your physician, all right? And if the physician's recommending one type of graft, research it, right? And let's you. My theory is when we come out of our physician's office and we know that we have to do surgery, I want my athlete knowing it's black and white, right? Then if they want to, go out and do your own homework on it. And if you need to, go get that famous second opinion, right? It's out there, but before you have any surgery, you should be rested up here that, okay, this is the best one for me and this is why I'm doing it.
Great stuff, guys. Next question, anyone? Come on, Pat.
I just wanted to know, how Ian's been feeling, because, have you had any of the migraines? Have you been doing okay since?
Yeah, she wants to ask Ian how you doing, how you feeling?
I'm good. You know
Everything's
what?
good with your
Everything's
eyesight,
good. My
everything?
brain just, the only thing I have is blurry vision in my right eye.
Oh, wow, that's
pretty much-
beautiful. I
pretty
mean,
much
I'm
it.
thankful that you're
Thank
feeling,
you.
you know.
Appreciate that. Thank you.
That was rough.
But, but again, I go back to why I did the surgery, why I'm working out like I am, because of that. Like I don't want to let the brain go. If I feel like if I let my body go, my brain's going to go with it.
No, it won't,
No,
no,
I-
because you
I-
won't let it. I know
Exactly,
you. You
exactly.
won't
But
let it.
I want to go back. I had a cadaver, and my ACL was a cadaver. Like I said, it was over 25 years ago. And when they did my partial knee replacement, they saw it and they said it's an unbelievable shape for it to be that old. And it was like, and the technology was way better than it was 25 years ago, obviously. But the recovery, they told me, you tell me that the recovery was quicker because I used the cadaver. I didn't have 2 spots to recover from. And it's been good, and that's how hopefully it's going to stay.
I actually have one too, guys. When you just talk about the hip and the knee, can there sometimes be a trigger that goes from your hip down to your knee? Because I've gone through back injuries and stuff, and I'm just wondering if it's, I know it's all joint, but how much of a connection is there between the two?
That's a great question, because a lot of time when I get referred patients, it can be a lot of times for knee pain. I get X-rays and their knee looks almost pristine. And one of the first things I do is ask about, is there any history of back injuries or nice catch? Or is there anything going on during their hips? Are they a back specialist or anybody for their hips? And almost always I get X-rays of both, of their back and their hips. Because the reality is, assuming that there's no back pathology or instruments causing kind of radiating pain, a lot of the nerve that innervates kind of our groin and going down to their legs, a lot of time can refer hip pain, hip arthritis can actually refer pain down to the knee. So a lot of patients, or not a lot, but there's a good percentage of patients that will come and say, my knees really hurt, but it's actually coming from their hips. It has to do with that dual innervation of referred pain. Similarly, how when you have a heart attack, it hurts in your chest, but you really feel a lot of pain in your arms. Similar to that stuff.
Any other questions? Come on up.
How often do you do a double knee replacement, or do you do one at a time?
How often do you do a double knee replacement, or do you do one at a time?
Really very good question. So, not very often will I do a bilateral knee replacement at the same time. I take the stage of them. There are indications in which I will do so. It's a lot more taxing on the body. It's a lot more inflammatory storm. Almost certainly going to go to rehab, stay in the hospital a little longer. Very different than what we're doing now with a lot of the technology we do with robotics, decreased blood loss, muscle sparing techniques where we're cutting less bone and such, and people are going home the same day or the day after. When it comes to a bilateral, it's a lot more taxing the body. So some of the indications that we will use are no history of deep vein thrombosis or pulmonary embolism. It's just a high risk. Things that being less than 70 is a risk factor as well. Having any history of, we talked about any history of clotting in the past, any history of cancers, things like that are really going to push you away from doing so. Some indication to do so, one of my only ones, would be if you have such a severe deformity of bow-legged or kind of what's called a valgus knee or knock knee. If it's so, what we tend to do, we'll straighten it out. We correct the deformity in surgery, but if it's such a deformity ahead of time, both knees, if I straighten one out, it could straighten them. It could be such a difference compared to the other leg now that can inhibit your rehabilitation. So in those patients, I will do, as long as they check out the other factors, I'll do a double knee replacement at that point. Most of the time, it's staged 6 weeks to 3 weeks apart.
And I'll just follow up with you on that, Jimmy. What does the recovery look like on a double knee replacement?
Wow. Fortunately, I don't have to see them that often. We do have some of our older players that that have them done, and they take a while because what would you say, anywhere between 4 to 6 months for one, right? And let's say you're in your 70s, and they're going for a double, right? It's not one, you need a commitment from your significant other for sure. Yeah, because you're not going to be getting around for a little bit with the double knee replacement. But, for time loss you're back functionally, right? Functionally, you're back about 3 to 4 weeks driving maybe, if it's your right leg. And functionally doing everything maybe about 6 weeks, 7 weeks. But fully, it could take up to a year, correct?
So it could. It absolutely could. What I usually tell all my patients that are undergoing a single or a total knee replacement, I usually say, 6 to 8 weeks for get back to most of what you want to do. And the reality is, I always tell them, mentally prepare for 10 to 12 weeks because everyone's a little bit different. As far as driving, I usually say about a month to my patients. If it's the left leg, I can usually get them back to driving in about 2 weeks, as long as they're off their narcotic medications, at least no significant assistive devices, off their walker, canes are okay. The right leg becomes a little troubling because there's there's interesting studies that have gone recently that talked about this, and it's really the reaction time is decreased until about that 2 to 3 week mark. So I usually say a month, and sometimes I get you back in 3 weeks.
We have time for one more quick question. If someone's got one, get yourself another t-shirt. You're both going to get one anyway. Come on. You're up next week. You had one last week.
What's your name?
Julie, just kind of switching gears from knees to hips, because you had mentioned that maybe needing, a double hip replacement. And if I remember, he always had hip flexor issues. Is that what caused him needing the hip replacements?
Imperial had some interesting hips, and so interesting, I'm sure you're familiar with Dr. Mills up in Boston, the hospital, Children's Hospital in Boston. He was actually mentoring me through Ontario's rehab process that would to keep him on the ice. It got so bad, I can remember walking through the airport in one of the Canadian airports where they usually put us in the last gate as far as you can possibly walk, but for Ontario to walk up the ramp, couldn't do it. And we literally had to carry all this luggage for him, and he kind of had a shuffle up there. But for him, when he was on the ice, he felt the best he possibly could feel.
You would never know.
No, but it finally just wore away, and so lucky him that he was being followed by a real good doc, and today he's living a good life. Yeah, so he's doing well.
Great stuff, guys, and gals, thanks for coming out here. Again, osteoarthritis is the most prevalent joint disease in the world. It's strongly linked to aging and obesity, and it is the #1 reason that athletes in all pro sports usually have their career cut short. So thanks for joining us. An interesting week. I'd like to thank Dr. Jason Mora, Jim McCrossin from the Philadelphia Flyers, Ian Laperrière, former NHL player and assistant coach. Golf clap. And I am Chris Therien. I'd like to thank our sponsors, as always, for hosting Total Turf Experience here in Pittman. Recon Sports with Reconstructive Orthopedics, which is right in there. The Energy Lab, where sports meet science, and Brilliant Smiles by Cindy. So, again, thank you guys. We will be back next Wednesday for our next Sports Medicine Forum. And for all of us here, thank you very much. We'll see you next Wednesday.